Good morning. Today I'm going to talk about the common thing which we see during the pediatric practice. It's hemolytic uremic syndrome in children. Basically, I will talk in children mostly. Okay. As you know that hemolytic uremic syndrome it's a clinical syndrome. Okay. It is characterized by thrombotic microangiopathy, characterized by classical trait of microangiopathy, hemolytic anemia, due to non-immune destruction of red blood cells within the microvasculature. Thrombocytopenia will be there, resulting from the platelet consumption in microvascular thrombi, and there will be acute renal failure, which is caused by thrombotic occlusion and endothelial injury of the renal microvasculature. Incidence, actually, it has been reported around 3 to 5% per cases per 100,000 children annually. The most common cause of acute kidney injury worldwide. Okay, so the peak highest susceptibility is seen under the children 5 years, below 5 years, but some reported cases are there up to 10 years. It is caused by Shiga toxin producing E. coli, okay, which accounts up to 90 to 92% of pediatric cases in developed nation, and approximately 10 to 15% of the children will infect with STES, that is Shiga toxin producing E. coli, will progress to develop clinical HUS within 5 to 13 days. The impact of this is that 4.5% of the children will require chronic renal replacement therapy, those who have HUS. Classification, there are a couple of people had been labeled or classified in primary and secondary, or typical or atypical. Okay, so mostly typical and atypical is been used. The typical HUS, typical hemolytic uremic syndrome, it is caused due to Shiga toxin producing E. coli, okay, which is accounting more than 90%. Some reported are up to 90 to 95% in pediatric cases. Okay, it will be preceded with diarrheal prodrome. Okay, and atypical will not have diarrhea. Okay, it account roughly 5 to 7%. And there will be a genetic complement dysregulation or mutation. In this, there will be no diarrhea. And another subclassification is that there is an enzyme which helps for clotting. It is ADAMTS13 deficiency. Okay, it can be familial. Usually in children, it is rare. Okay, it is mostly in adult. And acquired cause can be mostly in adult or older children. It is associated with anti-DMS13 antibodies, presence of antibodies which will have deficiency of clotting. Okay, and there will be manifestation of clinical frank TTP, means thrombocytopenia purpura. Okay, this is an outline of classification of HUS. Okay, it can be primary or secondary. As you know that mostly the secondary in that infective is the causative organism. The causative organism can be bacterial, viral, okay, or medications also. So the E. coli is E. coli 0157H7 is the most causative organism. Strep pneumoniae can be there. HIV infection, SARS, influenza A can all be the cause of having HUS in children. Other complement-related things, there is another classification for that, and medications, cyclosporine and all can also cause, or malignancy can also cause secondary HUS. STES associated HUS, like Shigella producing or Shiga toxin producing E. coli associated HUS. In developed country, the E. coli serotype 0157H7 is the most common. But Shigella dysentery is also there, and Salmonella also been involved with this. In developed country, Shigella dysentery serotype is the one. Okay. Source of infection, how it causes. Okay, mostly it is because of fecal-oral transmission. Okay, it happens because of milk consumption or animal product which was incompletely cooked, or veggies, salads, or drinking water contaminated by bacteria sheds in animal feces or animal waste. Pathophysiology, once the consumption of undercooked meat or contaminated water or vegetable happens, E. coli 0157H7 or Shigella dysentery releases Shiga toxin, which toxins binds to GB3 receptor on renal microvasculature endothelium, which forms a thrombi, okay, and which will have a platelet deposition. Hallmark of histopathological hallmark of hemolytic uremic syndrome is thrombotic microangiopathy. Okay, it is characterized by capillary endothelial damage, macrovascular formation of platelet fibrin plaques. This induced tissue ischemia. This will lead to damage to erythrocytes, which will lead to consumption of thrombocytopenia. Incubation period, once the symptoms will begin 3 to 8 days after ingestion of Shigella toxin producing E. coli, which is contaminated with food and water. Initial phase, there will be no bloody diarrhea. There will be severe abdominal cramp. There will be it can often associated with vomiting. Fever will be there, but it's mostly low grade, or absent fever will be there. Okay. Hemorrhagic colitis will be the second phase, will come within 1 to 3 days after the diarrhea becomes frank, bloody, which is the hallmark sign of HUS. There will be abdominal pain, can mimic appendicitis or intussusception. The TMS, the thrombotic microangiopathic ischemia phase, like HUS, typically develop in 5 to 10 days after the onset of diarrhea, often just as the GI symptoms. Once the GI symptoms are resolving, then this phase can start happening after 5 to 10 days. Clinical presentation. In acute phase, there will be, because of bleeding and all, there will be anemia and bleeding. There will be rapid onset of symptoms related to triad, like sudden profound pallor and lethargy. There will be tachycardia, potential high outflow murmur, petechia or purpura will be there, though it is least common. Major bleeding is uncommon despite thrombocytopenia. Renal involvement will be, there will be rapid decline in glomerular filtration rate. There will be oliguria, there will be strict anuria, there will be peripheral edema and weight gain, and severe volume-dependent hypertension. Extrarenal manifestation will be neurological, which is one of the greatest risk of morbidity. It occurs in 25% of pediatric HUS patients. There will be spectral ranging from irritability, lethargy, generalized tonic-clonic convulsion, coma, or cortical blindness. The etiology is that microvascular thrombi within the CNS will lead to severe uremia or hypertensive encephalopathy. When this happens, then immediately PICU escalation and aggressive blood pressure management should be done. The morbidity drive is the severe neurological involvement remain the leading cause of acute mortality in modern era of HUS. GI involvement or cardiac involvement, it will lead to, like beyond the standard colitis, there will be severe TMA, thrombotic TIA can cause bowel ischemia, lead to colonic necrosis, stricture, or perforation. Transaminitis and acute pancreatitis are well-documented complications requiring monitoring. Cardiovascular, there will be a microthrombi in coronary vessels, which can lead to myocardial ischemia and will lead to elevated troponin. There will be severe fluid overload, which will cause risk for congestive heart failure or pulmonary edema. Investigations. Basically, we have to stabilize the patient, and blood tests should be run. CBC, peripheral blood smear, is one of the hallmark to diagnose HUS with schistocytes. There will be reticulocyte count will be increased, LDH will be increased because of hemolysis. Bilirubin unconjugated will be increased. Renal involvement will lead to creatinine urea abnormalities. In urine analysis, it will show hemoglobinopathy, hemoglobinuria or hematuria, and proteinuria. This is the, you can see here, this is the fragmented erythrocytes, which is called schistocytes, is the hallmark on peripheral examination. More than 2% schistocyte is the diagnostic in this condition. Another thing is to investigate the cause of dysentery. In patient with diarrhea, there will be identification of pathogenic E. coli producing E. coli delta E. coli 0157H7 or Shigella is performed by stool culture. Further serotype by agglutination or enzyme immunoassay. Nowadays, PCR is the one which gives you early diagnosis. Rarely, hemolytic uremic syndrome can be occur within E. coli UTI. Okay. So once the urine cultures are indicated in non-diarrheal patients when there is no dysentery and you suspect of HUS. Bacteriological culture of body fluids are indicated in suspected pneumococcal disease, which is treatable once early use of antibiotic in this kind of conditions, which will prevent HUS in future. Okay, so we can do culture for sputum, CSF examination, blood culture to rule out any other septicemia or DIC, or culture for the pus. Diagnosis. It is hardly to distinguish between from the thrombocytopenic purpura and HUS. The laboratory features are identical in both of the cases. Not every case of HUS can be presented by diarrhea. So atypical and typical it can be there. So HUS is characterized by, as you know, that there will be hemolytic anemia, thrombocytopenia, and acute renal failure. But in TTP or thrombocytopenia purpura, there will be fever can be the hallmark, okay, and neurological symptoms are often present. But this is not always in every case. There will be a pericardial rub because of hemolysis and all, or infection can cause sometime you heard on auscultation. There will be these two conditions can mimic each other. So sometimes you have to treat as a single entity, okay. HUS and TTP should be treated as a single entity. This is the differential diagnosis between HUS and TTP. You will see that the platelet count will be between 40,000 to 80,000, but in TTP it can reduce less than 20,000. And ADAM-TS activity, which will be more than 20% in HUS, typical HUS, but it will be severely deficient in TTP. The pathophysiology, you can see that there will be endothelial toxins or complement. And in TTP, there will be a 1 Willebrand factor deficiency. So before giving any plasma therapy, they have to do this ADTM TS13 and a prior activity by blood test. Differential diagnosis is vast. You can see once it can mimic as acute abdomen, it can be acute gastroenteritis, can be appendicitis, can be intussusception, can be colitis. Okay, and sometime with severe sepsis, it looks like DIC because of thrombocytopenia. There will be suspect of inflammatory bowel disease, lupus, or thrombocytopenic purpura, or thrombotic thrombocytopenia. Management, especially HUS, is purely supportive. It's purely supportive. Initial management is supportive. Once there is a diarrhea, you have to be supportive therapy. Antibiotic use is reserved for certain kind of bacterial causative organism. Plasma therapy for atypical or reduced activity additive is 13, or miscellaneous treatment with immunosuppressant and all. So supportive therapy in all patients in primary and acute phase, there should be close monitoring of fluid status, blood pressure monitoring, neurological evaluation. Watch out for ventricular parameters, especially ventilator parameters, especially if there is any requirement for collapse, extracorporeal collapse, and all, DIC and all. Continuous monitoring of blood glucose, electrolytes, urea, creatinine. Hemogram has been, like CBC, should be monitored for further infection and for anemia and low platelets. In certain countries in this part of the world, I didn't see that much use of anti-motility therapy in pediatrics. But in certain countries, they use a lot, especially those who comes with diarrhea. Okay, so it can be associated. It is associated with HUS, hemolytic uremic syndrome, and which can lead to acute renal failure. Okay, in acute renal failure, there should be fluid restrictions and diuretics. Should not overhydrate the patient, which can lead to further complications. Antibiotics has been one of the leading cause in so many countries, especially once you use empirical antibiotic, beta-lactamidase, fluorochloridone, and other antibiotics, when irrespective of knowing the diagnosis, okay, can lead to HUS. So it has been reserved for especially pneumococcal, streptococcal pneumonia, okay, or Shigella dysentery. They can use it. Okay, so use of antibiotic is very, very cautiously been used during the initial phase of HUS or hemolytic uremic syndrome. Plasma therapy, it is mostly been reserved for atypical hemolytic uremic syndrome, especially if there is a complement abnormality factor abnormality or deficiency of ADTMS deficiency. The replacement of deficient factor with fresh frozen plasma, there will be daily infusion between 10 to 20 ml per kg per day. There will be exchange rate of 1.5 times plasma volume using FFP. Miscellaneous, the infant with hemolytic associated uremic syndrome with cobalamin abnormality can be treated with hydroxycobalamin, proper oral hygienic, oral betadine, folic acid should be used. And the normalization, the metabolic abnormality can help to prevent further episodes of HUS or hemolytic uremic syndrome. In patient with persistent ADTMS 13 antibodies and poor response to plasma exchange, immunosuppressive therapy with high dose of steroids or cyclophosphamide or cyclosporine or rituximab can be used. Splenectomy is one of the hallmark of can be is been done in this where there is a low plate, especially in HUS. Prevention. When the patient is infected with E. coli, okay, Shigella producing toxin E. coli, especially E. coli 10157H7, attempt to prevent progression from the bloody diarrhea phase to post-diarrheal phase of HUS have been unsuccessful. The use of antibiotic and antibiotic drugs should not be recommended. There will be vigorous fluid repletion during the diarrheal phase of illness is associated with less severe renal involvement, and restriction of fluid, excessive IV fluids during the acute renal phase should be avoided. Prognosis. Hematological manifestation resolves within 1 to 2 weeks. Okay. The mortality rate in this, especially those who have neurological involvement, will be less than 5%. The cause of death includes hyperkalemia, congestive heart failure, and pulmonary hemorrhage. Poor marker for the prognosis. WBC more than 20,000 on presentation. There will be persistent oliguria or anuria. Renal histology shows glomerular microangiopathy affecting more than 50% of glomeruli. There will be arterial microangiopathy plus or minus cortical necrosis. These are the poor prognostic factors. In summary, hemolytic uremic syndrome is a clinical syndrome which is characterized by microangiopathic hemolytic anemia with acute renal failure and thrombocytopenia. Thrombotic microangiopathy is a hallmark of disease pathogenesis. Stress or non-stress associated HUS, like infective or non-infective HUS with E. coli 10157, most common cause of STEX HUS, like Shigella producing endotoxin E. coli. Strep pneumoniae for non-diarrheal form of HUS. Familial form of HUS usually associated with complement dysregulation, which you have to if you have a primary suspicion. And treatment of stress HUS like hemolytic uremic syndrome mainly support you with good prognosis. If you had been treating aggressively with antibiotic and all, can lead to acute renal failure. Key message: good sanitation with maintenance of food hygienic can prevent diarrheal associated hemolytic uremic syndrome. Supportive care with early dialysis support remains the cornerstone of management. Non-infective atypical HUS or hemolytic uremic syndrome should be treated rapidly with plasma therapy. Effort should be made to make an etiological diagnosis in case of should be made to make an etiological diagnosis in case of atypical HUS or hemolytic uremic syndrome as a treatment and prognosis is affected. Thank you.